Hello and welcome to this week's Health Report with me, Norman Swan. New research from Western Australia should make a difference to a lot of people heading for elective surgery. Maybe that's you, especially surgery that might involve blood loss and the risk of a blood transfusion. If you can avoid a blood transfusion, it's a good thing because safe as our blood supply is, transfusions still risk complications and rare infections, not to mention the expense. Dr Hamish Mace is an anaesthetist at Fiona Stanley Hospital in Perth and was one of the authors. I spoke to him this morning.
Thank you very much for having me.
Before we get into the meat of this particular study, what people don't realise is that WA probably transfuses fewer people pro rata than anywhere else in Australia after surgery.
Yes, that's correct, Norman. Western Australia was one of the first states in the world to wholesale take up patient blood management interventions, leading to quite a major reduction in our transfusion rates across our state, starting in probably about 2008 and going through to today.
And the reason for that wasn't just money.
No, it wasn't. There was a program that was designed by a whole lot of experts which implemented a package of interventions which started right from the preoperative space with anemia screening clinics through to intraoperative processes which reduced shed blood during operations.
So more careful surgery, that sort of thing?
More careful surgery, some anaesthetic interventions such as tranexamic acid which reduces bleeding, and also post-operative interventions which serve to, improve the patient's tolerance of anemia.
And one, of course, again, just holding off getting to the particular research in question, drives the audience nuts when I do this, is there's been controversy over the level of your hemoglobin, that's the stuff that carries oxygen in your blood, that you should have before you receive a transfusion in hospital. And that was one of the early things you did in Western Australia, is you made it much stricter before you could get a transfusion when you were in hospital.
Yes, for many years there's been arbitrary trigger threshold for giving a transfusion. But I guess the important thing to consider is what we're doing is we're not really treating a number, we're treating the patient in front of us. And what we're trying to do by give a transfusion is improve the patient oxygen delivery to the tissues. So we need to balance the oxygen delivery for individual patients with the individual risks of receiving a blood transfusion.
Now this paper, at last we're getting to the paper, Hamish. So this paper is on the pre-operative phase, because one of the things that you've been doing over the years is you found that if you found somebody with anemia, you fixed it up, their chances of getting a blood transfusion after surgery, even if they had some blood loss, was markedly reduced.
That's right. So the clinic that we set up in 2016 was a comprehensive anemia screening and treatment clinic. What we did in our clinic is we performed a panel of blood tests on patients looking for not only the anemia itself, but also the causes of anemia. And we're able to work out an algorithm whereby we could treat a vast majority of that anemia with iron infusions. We're able to treat patients anywhere between 1 to 4 weeks before surgery so that they could go into surgery with a much greater buffer and therefore avoid transfusion in the majority of cases.
And do better in surgery as well?
Anemia itself is independently associated with bad outcomes after surgery. The red blood cells and the hemoglobin transfer oxygen to tissues. Surgery and anaesthesia is a really important time for that patient to be receiving all that critical oxygen so that they can heal. So we think it's really important to not only treat and prevent anemia, but also reduce transfusion for the patients, if that's avoidable post-op.
So simply giving iron intravenously can actually very quickly correct anemia?
Yes, that's true. One of the most common causes of anemia in our patient population group, and in particular the bowel cancer population group that we studied, was iron deficiency. Those patients have iron deficiency either through bleeding as a response to their tumour or also from reduced absorption from either the effects of the chemotherapy or the inflammation from the cancer. Administering iron through the intravenous route allows that patient to use that iron to produce their own red blood cells beforehand, and therefore they go into surgery much better prepared than if they hadn't done that.
And were these public patients only or public and private?
This was a public hospital, but we also see some private patients through our clinic as well.
This was largely a cost study, and very briefly, what did you find in terms of whether it was worth the money spent?
We performed a 5-year retrospective cohort study of bowel cancer patients coming through our hospital. What we looked at as our primary outcome was number of red blood cells units transfused per 1,000 patients, but we also looked at hospitalisation cost. The most important finding that we found was that about 40% of the patients had either anemia or iron deficiency or both, which I think was a really important finding and also consistent with international literature. We were really pleased to show that we had a 52% reduction in patients being transfused in the screened patient population group. What we also found was that despite the cost of screening of about $330 per patient, that we were able to show a $3,700 decrease in total hospitalisation costs for these patients. Now, this cost is, we think, made up of the one-day reduction in length of stay that we were able to show and also a reduced overall complication rate for these patients.
So in Western Australia, I think it's fair to say that it's been led by anaesthetists and intensive care specialists to pioneer this through. But you've got surgeons on side. It's hard to do without surgeons being on side. My understanding of the rest of Australia, it's been really patchy whether surgeons have bought into this. And surgeons kind of do have to buy into it because the majority of elective surgery and even semi-elective surgery like bowel cancer surgery is done in the private sector. And therefore, can you set up this system in the private sector and are surgeons buying into it?
Change is really difficult to effect in medicine. On average, it takes about 17 years for research to be translated into practice. What an individual clinician needs to be really confident in is that the data that they're presented translates to their particular patient population group. I think we were able to show in our study that not only can we reduce costs for the patients, but that we can improve clinical outcomes in an Australian healthcare concept. So I think an individual Australian hospital or an individual Australian surgeon or in fact anaesthetist can take this study and be really confident that it directly translates to their patient population group.
But their spirit might be willing, but the medical benefits schedule, the private system, might not actually have the business model that allows them to do it because it's multidisciplinary.
It certainly is, and it's possible, I guess, in private practice with a little bit of investment and a little bit of thought, but yeah, overwhelmingly it's easier in the public system.
So it might be private health insurers need to step in and pony up some money for it.
We've shown that we can reduce costs, so I'm sure most insurance companies would be very interested in that.
Hamish, thanks for joining us on the Health Report.
Thank you very much for having me.
Dr Hamish Mace is an anaesthetist at the Fiona Stanley Hospital in Perth. This has been the Health Report with me, Norman Swan. Now, don't forget our new non-COVID feedback and question segment with Tegan Taylor. Email us at healthreport_rn@abc.net.au. healthreport_rn@abc.net.au. And on the Law Report this week, a story you shouldn't miss. The Victorian Court of Appeal has just handed down a decision that allows sentencing judges to consider an offender's personality disorder when calculating an appropriate prison term. Until now, Victorian judges could take into account mental illnesses and intellectual impairments, but not personality disorders. This landmark decision involved 19-year-old Delia Brown, who was jailed for lighting fires. That story on the Law Report. I'm Norman Swan. This has been the Health Report. See you next week.
You've been listening to an ABC podcast.